Yeah, welcome once again, Dr. TV Asokan sir. So
Yeah.
Asokan sir is well known among Stanley people. Me myself, I am also a Stanleyan. So he is the professor and HOD Department of Psychiatry in Sri Muthukumaran Medical College Hospital and Research Institute, Chennai. So he was the editor of Stanley Medical College Journal in 1977 and Honorary General Secretary, Indian Psychiatric Society, Tamil Nadu. Honorary General Secretary, Indian Psychiatric Society, South India in 2001 and 2003. National Executive Council Director, Indian Psychiatric Society, 1999 to 2002. Past Assistant Editor, History Section in Indian Journal of Psychiatry. And President of South Zone Branch of Indian Psychiatric Society in 2010. Faculty Member of Mental Health Task for Indian Psychiatric Society. President, Indian Psychiatric Society, 2014. And past President, Asian Federation of Psychiatric Association, Zonal Representative of South Asia World Psychiatric Association, Honorary Life Member of World Psychiatric Association, and Member of Preventive Psychiatric Committee, and Member of Conflict Management and Conflict Resolution. He has done a lot of oration, including the Professor A.S. Thambaya oration in 2017, Professor Dr. R. Nanjunrao Endowment oration in 2024, and he has 36 years of teaching experience, conducted PG quiz in psychiatry 25 times at state and regional and national level, presented and published papers in forensic psychiatry and sex in international national conferences, and he has also authored 3 chapters in textbooks of psychiatry and authored 3 books on mental health in Tamil. So we have a very eminent speaker. Over to Dr. Asokan sir on the topic on tobacco cessation. Please, sir.
My PowerPoint is there?
Yes, sir. You can share it, sir. We are not able to see it yet.
1 minute. You are able to see now?
Yes, sir. Yes, sir. Tobacco cessation strategies, we are able to see.
But not my photo?
Yeah, your photo is also seen, sir.
Right. But I'm not seeing it right. Fine.
Okay.
Very good evening. Shall I start, sir? Am I audible?
Yes, sir. Very much clear, sir.
Right,
Please, sir.
Very good evening. I'm Dr. Ashokan, psychiatrist, and another 20 minutes I'm going to discuss about tobacco cessation strategies. In this brief lecture, I'm going to discuss about various intervention strategies and other pros and cons of these strategies, and finally, probably the reality in my concluding remarks. Tobacco is considered to be a gateway drug, but unfortunately, people are not able to get away from the drug because of the simple reason of serious physical dependence or psychological dependence, and they have deleterious consequences at the time of withdrawal. What are the various intervention strategies? Behavioral therapy. This is historically based on learning the information about the first introduction of tobacco to the smoker. The initiating factors, perpetuating factors, or what are the maintaining factors? Was there any kind of a motivation to quit? Was there any brief or sustained abstinence? And what are the relapse signs? All these are analyzed. The physical, psychological, social, and cultural aspects are examined, and the life situations, especially the stressful life situations during which how the individual operated, whether it is a coping strategy, whether it's a minor or major, or a mature or a immature defenses, and a little bit information about health awareness, a little bit information about quality of life on cessation. All these were presented to the individual. Ultimately, the person is probably, instilled confidence to adhere the treatment. Second is the cognitive therapy. This is based on, again, behavioral principle. When a smoker is facing any kind of a situation, whether it's a positive or a negative situation, automatically he develops a thought. And the thought is resulting in unwanted emotions, which are not properly processed in the cognitive realm. And that is resulting in erroneous judgment, which is paving way for smoking behavior. What the therapist does, he asks the smoker to revisit that particular situation of the first time introduction of smoking. And the therapist asks him to think about other possible thoughts in an imaginative way. Then he asked the smoker to substitute the originally occurred automatic thought with the second level thought. Thus, it's possible to elevate the unwanted emotions, and thus it's possible to retrieve the previous psychological equilibrium. Cognitive behavior therapy is superior both alone and in combination with nicotine replacement therapy compared with NRT alone. Motivational interviewing, this can be implemented by any health professional, psychologist, psychiatrist, social worker, doctor, specialist. What exactly is happening here? This is a directive, non-confrontational, non-judgmental, active listening with an empathic attitude. I think the person is listening. Next level, what is listen is reflected to the individual, and that is probably creating a kind of an awareness, whether consciously or unconsciously, the person is knowing about the ill effects of smoking, and probably that is also paving way for quitting. Third, acceptance and commitment therapy. The problem with the smoker is that it is not aware of the problem. Once he becomes aware of the problem, next level is acceptance. I'm going to quit. I'm going to stop smoking. But on cessation, on abstinence, I'm going to experience hell of a lot of physical and psychological problem I'm going to withstand. So acceptance is the second level. Then third, commitment. Commitment focuses on what is valued by him. And that is a way to really focus on the motivation to give up smoking. This particular concept is adapted in smartphone applications and web-based interventions. Contingency management and monetary incentive. This is based on a fundamental principle called token economy in the Hospital of Illinois, formulated by Oilan and Esrin. They were treating schizophrenic patients. Most of the schizophrenic patients are chronic with the negative symptoms. They were said to be in a kind of a vegetative state. And the therapist wanted them to really do a meaningful work, but unfortunately, they were not able to achieve this expected behavior. They thought through some other desired behavior, they could achieve this expected behavior, and here comes the incentive. In an American milieu, in a particular working organization, I think workers know they were selected. Smokers were given a promise that their health insurance policy would be borne, the expenses would be borne by the company. And that was really, a launching pad, and that paid some dividends. But unfortunately, it was not acceptable to other workers who were not smokers. But in the name of the welfare measures, I think that was implemented. But the success of incentive programs depends on the behavior that that is being incentivized, whether if the person is going to quit or whether he's going to submit himself for treatment, and how the incentive is framed, whether the incentive is going to be a reward or a punishment. This has to be designed properly, otherwise I think it will not work. But more research is needed in this particular incentive program, in which effect is really, whether it is maybe a short-term gain may be there, but in the long run, other factors have to be incorporated. Relapse prevention and recovery strategies. It equips smokers with skills for avoiding with high-risk environment. Imagine a person has abstained from smoking, but he is surrounded by most of the smokers in the work milieu. He is almost like an unlit camphor surrounded by an array of fire. At that time, I think he has to really operate his intellect rather than becoming a prey to his emotions. Acceptance commitment therapy, already know I discussed about it. Then motivation enhancing intervention. Periodically, the individual has to be subjected for intensive face-to-face counseling in order to maintain a sustained quit rate. Intervention delivery modalities, self-help materials in a printed format, I think it's really encouraging, but unless until it is tailored to the personal level, it's not going to be effective. Face-to-face counseling, that's a gold standard of all the behavioral treatment, because the therapist has got an opportunity to really, see the patient in person, the smoker in person. And probably he may be asking you, do you consider it as a problem? The smoker may say, no, I don't have a problem. I just smoke at any point of time. I can stop the smoking. This is a classical denial. And why the hell you're smoking? This particular question, when it is framed, the smoker may retort. No, 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 I just want to forget my agonizing memories. I just want to really concentrate. I feel better. I'm able to focus my attention, concentration during exam time. And it's possible to burn the midnight oil. This is another classical behavior, rationalizing behavior that can be confronted at the time of face-to-face counseling. And that's a period where I think assessment of the motivation is done and the best possible intervention procedure may be chosen by the therapist. Most of the time, I think smokers, they come into contact with the medical professionals. A brief clinician delivery is 5 years. Ask all the patients whether they are smoking or not. Advise, second year, advise to quit. Then third year, assess the patient's willingness to quit. Then assist in quit attempt and arrange for follow. Intensive face-to-face counseling, sometimes it's coupled with the pharmacological interventions, especially for the heavy smokers. I think periodic counseling is necessary. Technology-mediated delivery approaches, telephone-based quick lines, they make a very tall climb, but again, unless until it is incorporating a personal information, the person should feel that it is really, information is really personal to him, and there should not be any kind of an alien feeling in all the information disseminated in all these quick lines. Health-based interventions, it reduces time, cost, and remotely it can monitor, track, respond to, and deliver an intervention. The cost of delivery is low, but again, there should be multi-call approaches. And outcome is very good with reference to 6 months, but in the long run, I think there is no significant difference between the control and the treatment group. Web-based interventions, they make a tall climb, but again, research is needed to understand what are the specific components that can further enhance the effectiveness of all these interventions. We are living in the world of technology. Empty number of applications are available for anything and everything. But one has to choose the relevant smartphone application. For example, in 2021, there were 228 applications, including 152 on Android platforms and 120 on iOS platforms. But only 12 applications in 2021 and 11 in 22 had published the results. So when you're going for applications, smartphone applications, identify whether it is relevant, evidence-based. And there is a cause and effect relationship between psychological issues and addiction. So there should be comprehensive evaluation of mental health issues that has to be incorporated in all these applications. Pharmacological treatment, there are 3 drugs. One is the nicotine, second is the bupropion, and third is the vernaculine. Nicotine is available in the form of patch, gum, lozenge, nasal spray, oral inhaler, 2 milligram or 4 milligram. Heavy smokers, they may be needing higher dose. Nicotine replacement therapy delivers nicotine to alleviate the physical dependence without exposing the individual to the toxic materials generated by combustion and other additives. And not only that, it delivers the nicotine in a lesser concentration, that thereby reducing the behaviorally reinforcing effect of smoking. All NRTs have same efficacy, but heavy smokers, they have higher dose of NRT, more than 4 milligram, or dual regimens of NRT. Bupropion, it blocks reuptake of dopamine and to lesser extent of norepinephrine. Again, it blocks nicotine receptor. It increases dopamine and norepinephrine in the brain, stimulating the nicotine effect. In rats, low bupropion blocks the nicotine rewarding effect. So it's ideal to really, initiate bupropion to really address the withdrawal symptoms. Start with 150 milligram, escalate up to 300 milligram. If the individual is not tolerating, revert back to 150 milligram, which is still a beneficial dose. It is resulting in less weight gain, but the quick trades between bupropion and placebo after 1 year, there is no significant difference. Side effects, very rarely mood changes,
Hello.
may be
Sorry.
requiring hospitalization. Vernaculine, it's a partial agonist of alpha-4 beta-2 nicotine acetylcholine receptor subtype, which mediates dopamine release. This is a major receptor in nicotine addiction. Activating the receptor produces 50% of nicotine and thus it is relieving the nicotine withdrawal. Start with 0.5 milligram OD first day, fourth day 0.5 milligram BD, and 1 milligram BD on the seventh day. Vernaculine is more effective than placebo, nicotine patch, and bupropion. Side effects include nausea, vomiting, insomnia, and depression, psychosis, aggression, and suicidality. Combination pharmacotherapy for heavy smokers or people with lesser motivation, and if they start showing signs of relapse within the period of 6 months, I think dual regimens of NRT is better than single form of NRT. Vernaculine plus bupropion or NRT is better than vernaculine for heavy smokers. Bupropion plus nicotine patch better than bupropion alone. There is another concept of preloading medication. Imagine a situation where an individual wants to quit smoking on the New Year Eve. By even before that, by December 15th, a nicotine patch is probably given to him, and they compared an individual with the preloading and individual without preloading. They claim that the quit rate is more among the preloading people. Gradual reduction. Person smoking 20 cigarettes per day, that is being reduced to probably 15, 10, and 5. Again, this is construed as just maintenance of smoking and nothing else. May be ideal as an interim strategy. People who are not having any kind of a motivation, maybe, those people, I think they can be on this particular gradual reduction based on harm reduction concept. Extended treatment. NRT package should be used for only 8 to 12 weeks. After that, medications have to be initiated for a period of 1 year. Precision medicine, meta-analysis of all the researches with reference to smoking. I think they are probably encouraging results are there with reference to abstinence rate up to 6 months. But beyond 1 year, very, very few researches are there where quit rates are rarely surpassing 30%. So there is an impending need to find out a novel intervention strategy for these smokers. Smokers differ from each other in many ways. Metabolism, I think, slow versus rapid metabolism, I think that is an ideal factor to be really analyzed and further researched. Rapid metabolizers smoke heavily. CYP2A6 is the chief metabolizer of nicotine. CYP2A6 metabolizes nicotine, it's converting into cotinine, and that is further reduced to 3-hydroxycotinine. The cotinine 3-hydroxycotinine ratio is a biological marker of nicotine metabolism. And all these products, I think, metabolites, they can be measured in plasma, urine, and blood. Normal metabolizers, they respond better to bupropion than to nicotine patch. Slow metabolizers respond well to nicotine patch. Nicotine patch equally effective as vernaculine for slow metabolizers. Other precision medicine approaches based on pharmacogenomics, there's one particular study that was highlighting superior efficacy of vernaculine relative to bupropion and NRT. Females responded better than men. But again, mental health conditions can really, interfere the behavioral and pharmacological treatments. Combination treatments, I think highest quit rates are there with combination treatments. Modified and alternative tobacco products, very low nicotine content cigarettes. Decrease in nicotine with comprehensive cessation, there's a better impact. E-cigarettes, electronic nicotine delivery system. They are called as vapes, vape pens, tanks, mods, and pod mods. These are all battery device operated devices. There is a liquid called e-liquid, and the e-liquid is invariably vegetable glycerin or propylene glycol. And this particular e-liquid is converted into kind of an aerosol, which when inhaled, it really delivers nicotine, some flavorings, and other compounds. But again, evidence is inadequate for smoking cessation. Teachable moments. Smoker is coming into contact with the hospital. I think he may be admitted for some surgical procedure, or he may be submitting himself for some investigative procedure, or he may be hospitalized for tobacco-related distress. This is an ideal time to really, talk to him, and this is the ideal time to instill confidence, and probably, acceptance ratio is more, and these are the teachable moments. And lung cancer screening with low-dose computed tomography. that is associated with 20% lower mortality than a chest X-ray. This is the time I think you can really, possible for clinicians to deliver cessation intervention to this high-risk population. What are the evidences that are sufficient? Counseling and medication better than self-help group, because self-help groups, the person is not feeling it personal. Counseling and medication independently effective, more effective in combination. Combination is the rule for the smokers. Proactive quitline counseling alone or in combination with medication increases cessation. Short text message services, effective if they are interactive and tailored to the personal level. Web-based interventions effective only with behavioral techniques and interactive components. Combination of nicotine replacement therapy is better than single form of NRT. Teachable moments influence quit rates. The evidences that are insufficient, smartphone applications, they are generally saying something, but not really personally addressing. There is no use at all, and it is not evidence-based, and it is not peer-reviewed. Preloading medication, only very few papers are available, and very low nicotine content cigarettes, I think the smoking is maintained. E-cigarettes, no evidence at all. Interventions, further studies, no, they fail to replicate the findings. Cytosine, it is not really, alleviating smoking habits. In the present level, go for metabolism of nicotine. Normal metabolizers, I think they respond well to bupropion. Slow metabolizers go for nicotine if they are not responding, combined with bupropion. And rapid metabolizers, they have to be on intervention, combined intervention strategies. 6 months abstinence is construed as a better cessation, but unfortunately, researchers are not really encouraging beyond 6 months because only very rare, studies, rarely they say the quit rate is surpassing 30%. So heavy smokers, combined interventions are the rule of intervention. And probably the last one is my take-home point, I think, availability, affordability, accessibility. These are all the factors. In every general hospital, I think with reference to quit rate beyond 6 months or beyond 1 year, I think we are with a pessimistic cognitive pendulum, expecting a light in the other end of the tunnel. But with the formation of OP, outpatient department, in each and every general hospital with a multidisciplinary professionals comprising of psychologists, psychiatrists, physicians, other officials, I think it's possible to illuminate the tunnel itself. Thank you very much.
Thank you so much, sir, for your wonderful presentation and detailed explanation and clarity on tobacco cessation and also the mechanism. I think we can have the discussions and doubt clearing sessions at the end of all the three speakers.